Now, the next presenter we have lined up is Dr. Donna Ryan. Dr. Ryan is a professor emerita at Pennington Biomedical Research Center in Baton Rouge, Louisiana, where she oversaw clinical research for 25 years. Please welcome Dr. Ryan.
Thank you. Thank you very much. Can you hear me and can you see the slides? Yay! Okay. Hooray! Okay, so this is the roundtable on BMI and beyond, considering context in measuring obesity. So I'm a clinician and I have the clinical context. And so what I'm looking for is a measure that we can use to clinically define a disease in order to track its improvement with whatever treatment we're going to use. So the first thing you need to know is that when I retired from Pennington in 2012, I got a new career. And this is how I earn my livelihood. I do a lot of consultation with companies making lifestyle interventions, making medications, big pharma, little pharma. I also help companies making devices, so lots of industrial ties there, and you need to know that. I don't think any of that is particularly directly relevant to what I'm saying, but the other thing I do is I give a lot of continuing medical education lectures. So you're going to see how I talk about obesity and how I advise clinicians how to diagnose it and treat it. So Catherine is right. Obesity was not always considered a disease. It's really only been in this century that we consider it such. In fact, if you go back and look at how CMS and HCFA defined obesity, they said it was definitely not a disease, and that phrase was only removed in 2004. So yeah, the 21st century brought some changes, starting with those NIH guidelines that Catherine talked about in 1998, and then all of the societies developed white papers and position statements saying that obesity was indeed a disease, but it was really that AMA resolution that was the tipping point, and that was in 2013. So obesity is a disease, whether you believe this or not. If you disbelieve it, suspend disbelief for a minute and go with me on this. If it is a disease, it should have an etiology and a pathogenesis, right? Well, what is the pathogenesis of obesity? How does it cause all of these manifestations that we readily identify as diseases, like type 2 diabetes, like metabolic syndrome, like hypertension, cardiovascular disease, the 13 cancers that are associated with obesity? Well, obesity is a direct driver of some of these, and I think type 2 diabetes is the best example. With 42% of the U.S. population now having a BMI of 30 and higher, look, we've got a lot of type 2 diabetes on our hands. And in fact, 33% of those covered by Medicare have diabetes. So there's that really close link with that metabolic manifestation of obesity. But for some of these, obesity is just one risk factor. For example, in hypertension. So what is going on there? How is obesity driving ill health? I love this talk. It was given by Steve O'Reilly for the Banting lecture at the ADA several years ago. And he used this wonderful metaphor of the soggy bathroom carpet. That is so British, but let me walk you through it, how it works. So ordinarily, when we consume more energy than we can expend in physical activity, that consumption is the faucet and the energy expenditure is the drain. We store that extra energy in fat in the bathtub. That's healthy. We need fat to be healthy. But when we exceed our ability to store healthy fat in adipose tissue depots, such as in the hips and thighs, that's very, very healthy. We overflow that fat storage depot and develop the soggy bathroom carpet. What a yucky metaphor, and that's for dysmetabolic disease. And so some people, like the South Asian phenotype, have a limited ability to store subcutaneous fat. They readily store fat in intra-abdominal and ectopic stores. That ectopic fat is bad, and we're going to be talking about that in a minute. But that ability to store fat in healthy fat stores is determined by age. it's across the by hormones across the menopausal transition. There's loss of deposition of subcutaneous fat in the hips and thighs, and increase in body fat viscerally. It's also driven by medications, lipodystrophy associated with some of the medications we use for AIDS is associated with a reduction in subcutaneous fat and an increase in visceral adiposity. So it's that soggy bathroom carpet, that yucky fat metaphor, that is really causing disease. And normal, healthy adipose tissue in the subcutaneous areas looks quite different, and it acts quite different than ectopic and visceral adipose tissue. That ectopic and visceral adipose tissue, if you look at it under the microscope, the fat cells are huge, they're bigger, they're hypertrophied. There's lots of helmet cells, which are dead and dying fat cells. It's infiltrated by macrophages, and it's producing lots of adipokines that are unhealthy. And those adipokines are prothrombotic and pro-inflammatory. So there is associated with this excess abnormal body fat, the real definition of obesity, there is associated with that this prothrombotic and pro-inflammatory systemic profile, and that's bad for our health. But it's also the location of that body fat that drives the pathogenesis of the complications of obesity. And so if you look at the example I'm showing you here is epicardial adipose tissue. The coronary arteries run right through that epicardial adipose tissue, and it's overlying directly adjacent to the myocardium. So the myocardial damage and the atherogenic profile of those coronary arteries is driven directly by local effects of those adverse cytokines. But look, fat is not only producing these metabolic abnormalities, the burden of excess abnormal body fat is also driving disease. So, for example, increased visceral adiposity causes increased interabdominal pressure and GERD, and excess adipose tissue around the neck constricts the airway and contributes that just the local mechanical burden contributes to obstructive sleep apnea. And I think stigma we have to admit, is one of the complications of obesity that's produced by just the extra body fat and producing a higher size that our culture, cultural biases cause problems, as Ted so eloquently described. So what I've been going on about here is how excess abnormal body fat, the way up, drives disease. But I want to talk a little bit about how losing weight, how reducing that excess abnormal body fat can promote health. The good news is that the way up and the way down are one and the same. So you don't have to achieve a normal body weight. You don't have to achieve a BMI of 25 or less, or even 30 or 35 or less to get a lot of health benefits. And the reason for that is that excess abnormal body fat is the first to go. So we lose ectopic and visceral adipose tissue preferentially, and that's good. So we can get a lot of health benefits with 5, 10, 15% weight loss, and that proportional weight loss is important. It doesn't matter what BMI you start with, that proportional weight loss has the same benefits. And it's because of that Steve O'Reilly's model of we don't need to remove all body fat. We just need to reduce the body fat that is causing the problem. So when we are mobilizing that ectopic and visceral fat preferentially, we're driving the health benefits, the real beauty of modest and moderate weight loss. So to illustrate that, I want to show you this from the diabetes prevention program. You know, there is a physiology of weight loss. Different tissues respond differently to different degrees of weight loss. Let me illustrate that with this relationship between glycemia and weight loss. You know, that link is so tight. In individuals who have impaired glucose tolerance, that was the population of the DPP. when they lose weight, they start to reduce their risk for progression to type 2 diabetes. Look at this. In the first 5 kilograms of weight loss, which corresponds to 5% weight loss, we get huge benefits in terms of diabetes risk reduction. The x-axis is change in weight from baseline in kilograms. The y-axis is diabetes incidence rate per 100 person years. And look, 10% weight loss, 10 kilograms of weight loss, you pretty much maximize the benefit. You can lose more weight, but because of that tight relationship, that 10% weight loss really produces enormous improvements in glycemia, enough to prevent progression to type 2 diabetes in almost everyone. Now, we think other diseases require more weight loss. It takes more weight loss to improve the symptoms of obstructive sleep apnea, for example. It probably takes more weight loss to have an effect on cardiovascular events measured in our cardiovascular outcome trials and such. But that is the beauty of moderate weight loss. So what happens in the clinic when we're trying to diagnose obesity? Well, the BMI is a core measure in the electronic health record. Every visit, we are faced with a BMI, and we've all been taught, according to the guidelines Mike Jensen chaired from 2013, 2014, that a BMI over 30 is obesity, and a BMI of 25 is overweight. We do provide different ethnicity with different cut points, and that is also recommended not only by the U.S. guidelines, by the WHO. Now, in terms of the diagnosis of obesity, the ICD-10 codes are not going away. It'll take several years before we'll get ICD-11. And in those codes, E66 is the code for overweight and obesity. We're trying to change those codes so that we would have obesity sort of mirror the BMI codes, because that's really the most practical and best thing we can do now. But I'm here to tell you that the diagnosis of obesity, the ICD-10 codes on the charts, does not occur in all cases. In fact, it occurs in only about half of the individuals who meet that BMI criteria. So if you look at Medicare claims for an obesity diagnosis, we know that the general population would have that about 42% would have a BMI of 30 or higher. Well, the Medicare claims, only 21% of Medicare claims have an obesity diagnosis on there. We're not diagnosing obesity on those claims because we don't get paid for it. We don't get paid for our interventions for obesity with regularity. So that's part of the problem. But BMI we all clinicians acknowledge it is not a measure of body health. Body size is being measured by BMI, and body size does not tell you what body health is. There are many valid criticisms of BMI. For individuals who have a BMI over 30, many of them have perfectly normal metabolic health. They may have increased muscle mass, as is shown here. They may not even have any of the symptoms of an excess burden of body fat. And at the same time, individuals who have a BMI of less than 25 may have excess abnormal body fat, and we're not picking it up with that BMI measure. So what do I teach my clinicians in all of my CME courses? I tell them that BMI is only a screening tool. Yeah, when the BMI is very high, that patient likely has excess abnormal body fat, but you must use your clinical judgment to determine the diagnosis of obesity. That cut point is only a guidance. It's strictly a screening tool. You need to look at the waist circumference. You need to look at all the cardiometabolic risk factors. You need to look at symptoms of excess burden of body fat. And if those things are present, if there's evidence of excess abnormal body fat, that's the clinical diagnosis of obesity. So we're not using BMI, hopefully, for our clinical diagnosis of obesity. At least that's what I'm trying to teach. What would be a better a better way to measure this? Well, I guess the gold standard would be DEXA, because it would tell you, fat mass, lean mass. It would tell you where the fat mass is located. It would measure bone density in addition. That would be good. But look, DEXA is associated with radiation. We cannot use this widely, and we cannot use it as a measure to follow people in our treatment. The bioimpedance measurements will give us a 5-compartment model of body fat mass, but it's not particularly accurate. So air displacement plethysmography measures your volume, and then if you know your weight, you can determine your percent body fat. It doesn't tell you where that body fat is, and it's a pain in the neck to get in that machine, and the machine is expensive. And finally, we have the digital anthropometry. I actually think this one may have a future. What it's doing is it's taking 4 pictures of you, front and back. All of you can put on your leotards or your bathing suits after this and go home and download Me 360s and determine your percent body fat. So it's measuring these circumferences. It will give you a waist circumference that's pretty accurate. And this percent body fat is the most accurate compared to DEXA. It's superior to bioimpedance. So what this is doing is it's measuring these circumferences, and from that it's calculating body volume. If you know the volume and you know the weight, you can determine, there's a formula, you can determine the percent body fat. This has an advantage in that it gives you the maximal body circumference midline at the waist circumference, so that would have some utility. But look, this tool has not been used in clinical studies, and it's not being used. It's not being used. We would need it longitudinally to see how well it tracks with our treatment results. Look, back to what Catherine says, we really need to find a way that is determining how much excess abnormal body fat we have and how much lean mass we have and how much lean mass we're preserving in our weight loss. When we lose weight just by cutting calories, we're losing both lean and fat. We'd like that to be about 20% 20% lean and 80% fat. But we don't really have a way of calculating this readily and easily in the clinic. So we very much need better tools for determining the clinical diagnosis and following our patients through their weight loss journeys. The purpose of weight loss in the clinic is to improve health. We're not particularly interested in what patients look like. I love patients no matter what their body size. I'm interested in their body health. But let's face it, BMI is here to stay. It's part of that electronic health record. We need something in addition to that to help us. We'll always need clinical judgment to make the clinical diagnosis of obesity. We have no readily available tools to replace BMI. And percent weight loss, we're using that now. We measure weight loss to judge our treatment because we know a certain percent total body weight loss corresponds to improvement in different surrogate measures. But we really want to have measures of body health to follow in seeing and helping patients lose weight to better improve their health. Digital anthropometry, I think, is going to come into use in the clinic, but it in itself is not an ideal tool. So I want to thank you all for listening to me in this clinical journey about BMI and its use.
Wonderful.
Yeah.